Good afternoon, and thank you for joining us today. My name is Robynne Craig, and I'm Strategic Communications Director for the Benioff Homelessness and Housing Initiative. BHHI generates evidence-based solutions to prevent and end homelessness. You can learn more about us on our website. Today's webinar is being recorded and will be available on our website in the next 2 weeks. Keep an eye on our social media channels and your email inbox for a notification when it's been posted. If you have questions during the webinar, please put them in the Q&A box and our panelists will answer them at the end as time allows. Throughout today's session, we'll be putting links in the chat for you to find out more information. If you have computer audio problems and need to listen in by phone, follow the switch to phone audio directions. Please note there is an online captioning tool available via Zoom. People experiencing homelessness in California face high rates of chronic disease and disability and numerous barriers to care. Nearly half of adults experiencing homelessness in California rate their health as poor or fair, about 4 times the rate in the general US population. These health challenges make it harder for people to secure and retain housing, and homelessness worsens health, trapping people in a vicious cycle. As the homeless population ages, these burdens deepen, with profound implications for individuals, communities, and the systems that serve them. Our new report, Toward Thriving, based on the California statewide study of people experiencing homelessness, examines the relationship between poor health and homelessness, the barriers people face in accessing care, and evidence-based recommendations for policymakers and leaders across our health, homelessness, and social services systems. You can download the report from our website. We're posting the link in the chat now. We encourage you to read and share the report. Next, I'd like to introduce you to our incredible panel. Margot Kushel is a professor of medicine at UCSF and the director of the UCSF Benioff Homelessness and Housing Initiative. She is the principal investigator of the California statewide study of people experiencing homelessness and author of our new report. Dr. Kushel's research focuses on the causes and consequences of homelessness and the evidence-based strategies to both end homelessness and mitigate its impacts on health. Robynne Rose-Haymer was a member of the CASPEH Lived Expertise Advisory Board. She currently works as Vice President of Programs at the San Diego Workforce Partnership. Robynne began her career as an on-the-ground practitioner, working directly with low-income families and communities of color on health and well-being and education issues. Michelle Schneiderman is Director of California Healthcare Foundation's People-Centered Care Team. Her work focuses on improving care for Californians, particularly those enrolled in Medi-Cal. She leads CHCF's efforts in the care of populations with complex needs, including older adults, people with serious behavioral health conditions, and people experiencing homelessness. Corinne Buchanan serves as Undersecretary at the California Health and Human Services Agency, where she leads policy development, implementation, and manages day-to-day operations. Corinne has spent nearly 20 years working on issues at the intersection of housing, homelessness, behavioral health, and criminal justice reform. Thank you to all of our panelists for joining us today. Here's a quick overview of what we'll be covering in today's webinar. We've just finished our opening remarks. Up next, we'll have findings and policy recommendations with Margot Kushel and Robynne Rose-Haymer. Next, we'll have insights and reactions with Michelle Schneiderman and Corinne Buchanan. Lastly, we'll have a roundtable discussion, and we encourage you to place any questions that you have for the panelists into the Q&A throughout the webinar. Margot Kushel will start us off.
Thank you so much, Robynne. Our new report, Towards Thriving, is based on our data from the California statewide study of people experiencing homelessness. This is the largest representative study of homelessness in the United States since the 1990s, Just a note, because this was a cross-sectional study or a study that happened at one point in time, what we find is representative of who is homeless at this moment, not who ever experienced homelessness. We did this study at the request of the California Health and Human Services Agency. As one of our participants said, most of the time we're running around trying to figure out where we're going to sleep at night. We're not worried about going to the doctors or going to see somebody or going to get help with our mental state. When we think about homelessness, health, I really think about it as a feedback loop. Physical and behavioral health problems increase an individual's risk of homelessness. Once homeless, people experience higher rates of trauma. Higher rates of trauma likewise increase physical and behavioral health problems, but you could run the loop in any directions. Experiencing homelessness increases the risk of physical and behavioral health problems, which increase the risk of trauma, and vice versa. Now, I am going to turn it back over to Robynne Rose-Haymer to take us through some of our results.
Thanks, Margot. The median age of the persons experiencing homelessness was 47 years old. 44% of the adults were over the age of 50, and 41% of this group first became homeless at age 50 or older. The gender was of the people experiencing homelessness was self-disclosed. 69% of the persons experiencing homelessness were cisgender men, 30% cisgender women, and 1% was transgender, non-binary, or other gender identified. 26% reported a Black racial identity, 3% reported a Native American, Alaskan, or Indigenous identity, and 26% reported a Latino, Latin, or Latinx identity. The places where most folks slept in the prior 6 months were 78% unsheltered. 21% of that was in a vehicle, and 57% of that was in a non-vehicle, and 22% were sheltered. As one respondent said, I stayed at a motel program they had running during COVID. I have Graves' disease, so I have no immune system. It was nice being off the streets. It was real nice having a shower and roof over my head. I didn't expect to have to come back out here, especially being almost 60 years old. It's rough out here. It's rough. "45% of respondents reported poor or fair health. Poor health increased with age. Latina adults were younger, yet had an equal likelihood of fair or poor health. 60% of respondents had one or more chronic health conditions, and 12% had three or more. A respondent told us, I need to schedule an appointment because they told me I have breast cancer. I couldn't charge my phone. So I'd have to take it into the drop-in center. When you're focusing on that and then trying to keep stuff clean, it escapes my mind that I need to call to make an appointment with the doctor. 18% of those 50 and older had three or more chronic health conditions. And now I'd like to turn it over to Margot.
So we found extremely high rates of smoking. 70% of participants currently smoke tobacco. 10% were former smokers. What this means were most people had a smoking history, but very few had quit. As one of our participants said, sometimes I wish I never started smoking cigarettes. Seeing my mother going through what she went through, my mother died because she had lung cancer and throat cancer from smoking cigarettes. And now I wish I never started smoking. 34% reported a difficulty with at least one of the activities of daily living, like bathing or dressing. 16% reported 3 or more limitations. This is associated with a risk of nursing home placement. Among adults 50 and older, 43% reported at least one ADL limitation, and 23% reported 3 or more. Overall, 22% of participants reported difficulty walking across a room. 20% used a mobility aid like a cane, walker, or wheelchair. Amongst adults 50 and older, 32% did. As one of our participants said, I had buddies had to come literally pick me up and carry me to the bathroom so I could use the bathroom. I couldn't even walk. Most of our participants reported having health insurance. 83% did, and this was primarily Medi-Cal or California's Medicaid program. Over half, or 52%, had a regular place to receive care that was not an emergency department. 39% reported having a primary care provider. And almost half, or 49%, had received some outpatient care, not in an emergency department, in the prior 6 months. Among those who were primarily sheltered, 53% had a primary care provider. Among those who were unsheltered, only 35% did.
Thanks, Margot. 22% of the respondents reported unmet need for healthcare, and 22% reported an unmet need for prescriptions. A respondent told us, so they gave me a 2-week supply, but I went to the pharmacy to pick it up. It costs $176. You need your ID. So I can't even pick up the medication the doctor's office is offering me because my wallet was stolen. I don't have the cash. Some of the barriers to obtaining health care were lack of transportation, limited access to the phone or internet, stigma, a difficulty managing appointments, and fear of losing belongings because people would have to leave their things in order to go to the doctor. Going through the physical stuff again really threw my mental, not being able to do anything about it because how do you make a phone call? How do you get a doctor's appointment when you don't have a car anymore? Like you don't even have a penny in your pocket, a respondent said. In the last 6 months, 37% visited an emergency department without being admitted. 21% were hospitalized for a physical health condition. There are high rates of emergency department and inpatient use. This reflects a high burden of illness and limited access to preventative and outpatient care. Some folks were discharged from hospitals directly to unsheltered settings, though some did access recuperative care programs when available. A respondent said, I just came back after 16 days. I got bit by a spider and it got infected. I had 4 surgeries and 2 blood transfusions. I came back and my tent and everything was robbed. So I started over again. It's hard if you try going to doctor's appointments.
As we're going to discuss in our discussion, we have a variety of policy recommendations based on these findings. I'm going to go through them quickly and then try to break them down, and then we'll have a discussion. Our first recommendation is to proactively enroll and retain people in Medicaid. In California, that's Medi-Cal. To deliver care in non-traditional settings, like street medicine or in shelters, to create responsive and integrated health system, to reimagine acute care and hospital transitions, and to enhance accessibility and health connections in shelters and outreach. And finally, to create accessible and supportive housing for the long term. Let me walk through these a little more slowly. First, to proactively enroll and retain people in Medicaid. We need to expand enrollment to make sure that every single person who meets criteria, and up until this moment in time, basically everyone experiencing homelessness does, and to ensure continual coverage. You may have heard of HR 1, which we'll talk about soon, but changes based on federal legislation will now create a churn where it will be important for us to keep people covered because they will be need to meet criteria to remain covered. Next slide. We need to continue to strengthen our ability to deliver care in non-traditional settings. We need to strengthen and scale street medicine or the provision of healthcare, meeting people where they are in unsheltered settings or in shelters. We need to enhance the provision of health services in shelters and in housing sites. Next slide. We need to create a responsive and integrated health system. There are models of care, such as the VA Homeless Pact, which is a system of providing primary care to people experiences homelessness that reduces barriers to care, that don't have people need to make an appointment to come in, that provides multidisciplinary trauma-informed care where people are. Next slide. We need to imagine acute care and hospital transitions, ensuring access to medications and essential support when people are discharged, to promote health and wellness through targeted interventions like addiction care and others, and to strengthen access and care quality through culturally tailored responsive care. Next slide. We need to continue to work to enhance accessibility and health connections in shelters and in outreach settings, ensuring physical accessibility and safety, empowering staff as healthcare connectors, delivering the right services in shelters and encampments, and to recognize access to technology as a lifelong, and to make sure that people have not only access to mobile devices, but have places to charge them and other things. Next slide. And we need to create accessible and supportive housing for the long term. There is no end to homelessness without affordable housing. And with the levels of disability and aging that we see, we need to make sure that that supply of housing is not only affordable, but accessible. We need to integrate services into into housing settings to allow people to thrive for the long term, including things like in-home supportive services for personal care and, when appropriate, on-site or roving healthcare teams. Now, I'd like to remind you to put your questions in the Q&A, and I encourage you to follow us on social media, on LinkedIn, on Blue Sky, to sign up for our reminders, to download the report. And now I'm going to send it over to Michelle Schneiderman for her reactions and insights.
Thanks, Margot and Robynne. I'm Michelle Schneiderman from the California Healthcare Foundation, and I'm so honored to have had the opportunity to support this incredible research and report. CHCF has been supporting work to better understand the needs of and improve the healthcare for Californians experiencing homelessness. This work is personal for me. I'm a physician by training, and during the almost 2 decades I worked at San Francisco General Hospital, I cared for many patients experiencing homelessness, and I saw firsthand the devastating physical toll that being unhoused takes on the human body. The data in this report confirms what clinicians see daily. Experiencing homelessness worsens health. While doctors can't effectively prescribe housing yet, the health system does have some tools right now to intervene effectively. care models that meet people where they are. This includes street medicine and medical respite programs, as you heard Dr. Kushel mention. We need to fundamentally rethink where care happens. Street medicine is the delivery of high-quality healthcare directly to people where they are, in encampments, under bridges, and alleys. It removes the physical and psychological barriers of having to enter a traditional brick-and-mortar clinic in order to receive care. For years, reimbursement rules made it difficult to provide full-scope medical care outside of a clinic setting. However, recent changes in Medi-Cal policy now allow providers to bill for services delivered on the street. This is a game changer for engagement and continuity of care. By recognizing the street as a legitimate clinical setting, providers can manage chronic conditions, perform wound care and other urgent interventions, and dispense medication where the patient is staying, providing care at the speed of trust. Over time, street medicine teams can work with their patients to address mental health and addiction, and eventually link patients to housing and ongoing care. CHCF has a number of resources about street medicine, including a few videos showcasing the work of 4 fabulous teams across the state. I think the links are going into the chat. Medical respite provides short-term residential care for people experiencing homelessness who are too ill to be on the street, but not sick enough to require hospital care. It gives people a safe place to recuperate, manage medications, learn all of the chronic disease self-management tools, and connect to physical and behavioral health specialists. Crucially, it provides a window of time for case managers to work on long-term housing solutions while the person is stable, rather than trying to coordinate housing while the person is in crisis on the street. I spent 10 years as the medical director of a medical respite program in San Francisco and saw firsthand the impact the program had on people's lives. A 28-year-old woman with severe heart failure cycling in and out of the hospital who stabilized her health and escaped domestic violence. A 68-year-old man with a new diagnosis of lung cancer who connected with oncology and reunited with grandchildren he hadn't seen in a decade, and so many others. Medical respite is a reimbursable community support under Medi-Cal. This means that managed care plans can pay for these stays, recognizing that a safe environment is a medical necessity for recovery. It's also a financially prudent thing to cover. Research shows it reduces hospital lengths of stay and readmissions, and CHCF has a collection of resources on medical respite as well, which you'll see in the chat. We're in a unique moment in California with Medi-Cal transformation. CalAIM and other reforms allow us to pay for services that address unmet social needs and recognize that housing is one of the most important determinants of health that we must address to achieve better health outcomes and health equity. The strides we've made must be preserved. And implementation of these reforms has worked best when done through robust cross-sector partnerships with homeless service providers and housing developers. They're great examples of where this kind of collaboration is happening and making a real difference. As one example, we'll put a link to some case studies on health and housing developer partnerships in the chat. I'll just end my reflection by saying that while the data in this report is heavy, we know what to do to build a future where systems work together seamlessly and care is delivered responsively so that people can be housed and healthy. And with that, I will hand it over to Corinne Buchanan.
Thank you so much, Dr. Schneiderman. So I first met Dr. Schneiderman when I got my start working on housing and homelessness policy in San Francisco. And I just want to say thank you for being a champion for the work that we're trying to accomplish through CalAIM. It means a ton and helps us be effective. So thank you. I also have to say shout out to Dr. Kushel and the team at the Benioff Housing and Homelessness Initiative at UCSF. This body of work has helped us drive good policy in California and beyond, and we are very grateful for your work. So I'm Corinne Buchanan. I serve as the Undersecretary at the California Health and Human Services Agency, and we are the umbrella organization that is made up of 12 health and human services departments in state government. And I want to start by sharing why this work is important to my role as undersecretary. And I think it's pretty easy and hopefully pretty easy to understand after the slides we've just been through that housing is health, period. In California, we have been really living this truth in our policy for many years, but it feels even more urgent that we highlight this linkage today in the federal policy context. Our North Star at the California Health and Human Services Agency is to create a healthy California for all. And so addressing the health and housing needs of Californians who are experiencing homelessness is a priority. I also want to share that I had a role in standing up a project called Project Room Key here in California, and it's something that I'm really proud to say because thanks to the very hard work of local partners up and down the state, we in California were able to stand up nearly 15,000 hotel rooms in a matter of months to be able to protect people experiencing homelessness in response to the COVID pandemic. And I want to bring up this experience because I think it showed us two really key things. The first is that when we act with urgency, we can create housing quickly. And it showed us that this work is doable. This is not an intangible problem. The work is possible. I know that many of the people who are listening today know this because you do it day in and day out, and we are forever grateful for that. Also, I think what we learned is that when we create truly housing first and low barrier models to care, that we can create stability and support that leads to more meaningful access to care that improves the health outcomes of the people we serve. So I want to share a little bit about how within the CalHHS world we're investing in housing. And I'm going to share two examples. One is through our Department of Social Services, which is embedding housing interventions into the social safety net to serve families through who are a part of our CalWorks program. We're serving families in the child welfare system. We're focused on serving seniors and people with disabilities. And we've also invested in capital funding for permanent supportive housing and assisted living settings to meet the needs of people experiencing homelessness. And then second, we've made really significant investments through our Department of Healthcare Services, and particularly through our CalAIM model that you heard Dr. Schneiderman talk about a little bit. For folks who aren't tracking, I want to help you understand that what we're trying to accomplish from a big picture on CalAIM is that what we want to offer is not just services provided by a doctor behind the four walls of a clinic or a hospital. Instead, what we are providing are the kinds of services that address the social drivers of health, very namely housing. The other thing that's different is who's providing that care. So again, we're also looking at a model where community health workers, case managers, housing specialists are also a part of the delivery model. And then lastly, where are we providing that care? And again, this is not behind the four walls of a clinic. This is meeting people where they're at to provide services. Want to also highlight that it sort of must be said in these times that we are working really hard to respond to the policy changes coming from the federal level. There are really significant and detrimental impacts from H.R. 1, otherwise known as the One Big Beautiful Bill Act, both to CalFresh and Medi-Cal, which will have negative impacts on both access and resources for these programs that will affect all Californians. But the burden is likely to be felt most strongly on individuals experiencing homelessness when new administrative burdens are exacerbated by the existing burdens that many people experiencing homelessness face when trying to access social safety net programs. And also, we're currently many of us responding to changes in the HUD, NOFO, the Homeless Continuum of Care system. And California has participated in a multi-state lawsuit to challenge the changes, which would have significant impacts in terms of reducing the availability of permanent supportive housing in our state, which we know is the solution to both improving housing outcomes and, very importantly for this webinar, health outcomes for Californians. So we have an ongoing commitment to serving all Californians and addressing the health and housing needs of these individuals. Thank you so much to the UCS SAFE team for having us and really looking forward to the conversation ahead. Thanks.
And thank you so much, Corinne and Michelle, for all of your support and for joining us today. I'd like to invite all the panelists to turn on their cameras, and we're going to just have a little chat while questions come in. And I see a lot of great questions from the community. So thank everyone for attending, and keep those questions coming in. We'll get to as many of them as we can. Michelle, maybe I'll start off with you with sort of like a two-part question. One is that we see very often that health crises can actually lead to homelessness. And so I'm wondering where you think we should be focusing prevention efforts, particularly in that setting where it's a health crisis that pushes someone over into homelessness, either because they lost their job or because they were hospitalized or the like. And then secondly, particularly in light of the aging population, although as we see from this report, it's a very sick population overall. What adjustments do you think we need to make to both our homeless services system and our system to meet the needs of people experiencing homelessness?
Thanks, Margot. I will take a stab at this, and I know you've done a ton of research on older adult homelessness, so I might pass it back to you to help fill in any of the gaps. I might flip my answers around, so start by answering your second question about older adult homelessness. The data is really clear. As you've demonstrated, the homeless population is graying. We see evidence of premature aging where unhoused individuals in their 50s are exhibiting the geriatric conditions and mobility limitations typically seen in housed people in their 70s or 80s. The healthcare delivery system and the broader delivery system, I think, has to adapt in several ways. Um, so, one way is expanding the capacity of shelter, medical respite, interim housing programs, and as you previously said, permanent supportive housing to work with outside assistance around supporting activities of daily living. Um, this can be done through several mechanisms. In California, we have a community support called the Personal Care and Homemaker Service Community Support, and we can leverage the In-Home Supportive Services Program. I think it would be really interesting to explore what it would take to scale something that's called contract mode in-home supportive services, which is really meant for people who can't sort of manage identifying, hiring, or supervising their own workers. Outreach teams, whether they're in the homeless or health sectors, could probably use training in the principles of older adult care so that they can attend to complex chronic conditions and mobility issues right on the street, know how to document what they see to ensure that folks get prioritized for the right kinds of health and housing supports. Um, Documentation is going to be really important, more so in the next few years, for applying and advocating for disability, SSI, and SSDI, and the more stable Medicaid that comes with that. Um, and to your earlier, to the first question, preventing older adult homelessness or preventing homelessness in the first place through strategic, targeted strategies, which could include screening for housing precarity in healthcare settings and working with medical legal partnerships. Um, as a doctor, I saw firsthand what it looked like for people to lose their housing during an extended hospitalization or nursing home stay. And I think that should be considered a hospital never event, right? On par with wrong site surgery. Like that should just be unacceptable. But would love for you to sort of fill in some of the gaps.
Yeah, I think that was a fantastic answer. And I think, as you said, looking also at hospitalization or at leveraging the healthcare system for prevention, both to create this never event for leaving extended stay hospitals. Now, for people with behavioral health disabilities, starting in uh, July or January, Corinne is going to correct me.
January.
When is that?
January.
In January, even better. Starting in January, there will be a 6-month transitional rent benefit through Medicaid. This will be a new Medicaid benefit. It's extremely exciting way to give people 6 months of rent. And I think the idea there is that homeless services organizations and housing organizations will use those 6 months to come up with a longer standing stability plan. But it means that someone can't stay in the hospital while they're waiting for like rental assistance to come through, but hopefully in these 6 months it could be. So I think that is an incredibly exciting adjustment. And I know, Michelle, you and I are both very excited about thinking about ways we could use the healthcare system as a way to screen people for prevention opportunities. In our research in CASPEH and in other research, one of the only places where people experiencing homelessness almost uniformly touched in the 6 months before they became homeless were safety net healthcare systems, which really makes the potential of healthcare systems being part of the prevention continuum in a really important play an important role. I'm going to turn it over now to Robynne Rose-Haymer. One of the things we found through our qualitative interviews, I heard you mention that, stigma was a major barrier, is a lack of trust in healthcare institutions and feeling stigmatized. How should health and homelessness systems work with trusted community partners to actually close these gaps in health and safety?
Thank you for that question. This is actually one of my most favorite topics. I appreciate Dr. Schneiderman for first raising the issue that trust does not come automatically. This is something that is built over time with positive contacts and reinforced appreciation for who someone is when they show up. So ultimately, many people are avoiding healthcare institutions because of their negative prior experiences or distrust about how their information is being used. And those systems can be strengthened by community-based navigation and outreach because those are trusted partners already. So if they're navigating them into the healthcare system in partnership, it creates a system where the person experiencing homelessness or housing instability already has a trusted relationship. Additionally, systems can embed healthcare navigators and outreach workers in street medicine teams and also in community settings that people rely on. And the system can fund community health workers who reflect the identities of folks experiencing homelessness and speak the language that is their native tongue. It's also important to co-develop health outreach efforts with organizations that understand the community and understand the fears of the people they serve. And those folks are represented on the teams. So ensuring that folks with lived experience are embedded in those organizations. And so there's a true partnership where trust can be built. And Margot, I know that Michelle has more to say about this, so I'd love to invite her to the conversation.
Robynne, I actually think you nailed the answer to that question. I don't have anything profound to add.
I'm seeing so many fabulous questions come in, and if you see me looking to my side, I'm looking at the questions coming in. Corinne, a few people have asked this, and I'm going to start throwing it to you. How would you say the state is approaching the federal health policy changes that could potentially impact people who are experiencing homelessness? So we have a bunch of questions on this, so take it in whatever direction you choose.
Okay. Well, I touched on this just briefly in the opening remarks, but we're experiencing some really significant policy changes. And I'll just say a little more about HR 1 and a bit about how we're approaching mitigating the harm that comes from HR 1, or otherwise known as the One Big Beautiful Bill Act. So which makes really big changes to Medi-Cal and CalFresh. So on the Medi-Cal side, we're facing the risk of up to 3.4 million members losing coverage and over $3 billion in funding annually that is at risk because of these policy changes, just to give you a sense of scale. On the CalFresh side, we're looking at cuts of between 1.7 to 3.7 billion in funding cuts and as many as 400,000 individuals who could lose coverage. So a big part of what these policy changes do is they create new administrative hurdles or burdens for individuals to access these benefits. And we know that this is likely, as I mentioned, to impact all Californians, but people experiencing homelessness are especially likely to be impacted as they face challenges in access and safely storing documentation, challenges with being able to receive notifications because they lack an address, challenges with transportation or not being able to leave their belongings unsupervised to be able to participate in the required visits that are associated with these changes. One other example of a significant change that will impact people experiencing homelessness in particular are work requirements that were previously exempted for people experiencing homelessness, which are no longer so under HR 1. So what we're trying to do as we think about the administration of this policy is how we can create opportunities so that we don't miss folks who might be exempt, that we don't lose access for individuals who should be eligible and should be able to continue to have access. So we're very focused on what are those exemptions, including health-related exemptions, since we learned today that we see disproportionate rates of poor health outcomes and chronic conditions for this population. And then also trying to figure out how we can automate the process of helping to ensure folks are meeting requirements, including work requirements, which are newly a big part of HR 1's changes and the administrative burden we expect to see. And then the other thing I want to say in terms of our approach to mitigating harm is that one of the big things that we are doing and will need to continue to invest in is listening to our community and listening to people with lived expertise in how we design and roll out these very challenging policies, listening to our service provider partners, listening to the advocacy community, and listening to what we learn from our friends who work on policy and research, like the information we're learning today. And putting especially the voices of those with lived expertise at the center of all of that. And then the second piece, in addition to listening, we're investing in how we communicate. So trying to very clearly in plain language help Californians understand how these policy changes may impact them and how they can mitigate the harm, and doing so in language and in an accessible way and in many forms of communication to make sure that we're also reaching people experiencing homelessness. So thanks for the question, and we have a lot more work to do. I think we're going to put in the chat, and we've got it there, a link where you can learn more about what HR 1 does to California and how we're responding to these significant and detrimental policy changes here in our state. So take a look we got a couple webinars, and we will keep updating them as we move forward in implementing the policies. Thanks.
Thanks so much, Karen, and thank you for everything that you personally and that the state is doing in the face of these really terrifying policies that could set us back far. I am seeing a lot of questions that I'm going to try to lump together a little bit, and those are sort of on how do we operationalize these things. We have many people in the chat writing about these changes to Medicaid. So for those of you who are new to it, we're using the term CalAIM, or you might hear it as the 1115 waiver, but it's basically a way to use Medicaid payments more flexibly. And then people might have heard of the Behavioral Health Services Act here in California, which is also bringing funding in for people with behavioral health challenges. So I'm going to ask, maybe this is to both Robynne and the rest, is how can we support peers better? There are people in the chat mentioning how important peer support is to health and to sort of well-being. How do we get those programs up and running? Are they billable to Medicaid and the like? Anyone want to take that?
Well, I'm happy to start about how to support. Medicaid billing is not my expertise, so I will definitely leave that to others. But how best to go about supporting peers is first pay them. There are many people with lived expertise who are very willing to participate in both project design and consultation around services, and they would do so willingly as part of a team. But to honor people who are putting their expertise into the mix as part of the solution, we should be sure that they are compensated for that work. And making sure that those meetings when we are designing programs are at a time when lived experts can participate. Genuinely, those folks are working. And if you hold meetings, community meetings to gather information and or project design meetings when they're at work, they then have to make a sacrifice. They want to serve their community and give back, but they also need to work to make sure that they do not return to homelessness. So ensuring that you're taking that feedback about when the best time to have meetings is and incorporating that into your actualization. Corinne or Michelle, do you want to talk about Medicare billing?
I can start.
No,
I
go
know
ahead.
just enough to be dangerous. I think we're putting in the chat a resource from the California Department of Healthcare Services about Medi-Cal billing for peers. So right now, most of the billing for peers is in the behavioral health side. So in California, there are Medi-Cal managed care plans that cover sort of mild to moderate behavioral health conditions and county-based mental health plans that cover more specialty services, and peers can actually be billed on the county side. As an analog, though, CalAIM does cover community health worker services. So not every community health worker is a peer. Many are just community connected folks, but some are. And I think that's an important way to think about sustaining this workforce. Corinne, do you want to add anything to that?
No, I think as I said, Dr. Schneiderman is a champion of this work and described it really well. I think we thank you, Robynne, for your words of how we also support in employment situations, people with lived expertise and community health workers, compensate them fairly, and how we really need to help message the successes and help people understand the vital role that community health workers and peers play in our delivery system. I get a chance to meet on a relatively regular basis with some peer support leaders in the state of California, and every time I leave with new inspiration for the work that this type of provider offers especially in our behavioral health system. So thanks for raising the question.
Corinne, I'm going to throw another one at you that's coming in. We were talking a lot about state, Medicaid, CalAIM, et cetera. Someone is asking, what are some of the promising practices to address the confluence of both housing and health needs, but at the local level?
Yeah, I love this question. I spent much of my career working at the local level, so I am at the state now, but my heart is really in the county world, and so I have been incredibly impressed with some new work happening across the state to expand the use of what are called flexible housing subsidy pools. And the idea, this is a totally California homegrown model of creating a coordinated rental subsidy administration model so that housing location can be centralized and streamlined. And it also, very importantly, allows for different funding sources to be braided. And I think that is braiding our funding sources is something we've always had to do in our homeless response world. It's just part of it's our bread and butter. It's part of what we have to do to make these projects and these initiatives pencil. But I think it's even more so. We talked about how in January meaning like 25 days from now, it's a pretty exciting moment. We're going to be launching for the first time ever a community support, which is a benefit called transitional rent, which will provide up to 6 months of rent through our Medi-Cal program, focused on the behavioral health population to start, and making sure that those dollars can be connected to our broader homeless response system so that we are effectively leveraging them. And then also making sure that we're connecting, Dr. Kushel also mentioned this, to the Behavioral Health Services Act, which is also known as the Millionaire's Tax, but it's a fund source that comes into the state of California and to our local partners at the counties to focus our behavioral health system, I would say, or help us orient our behavioral health system to meeting the needs of individuals who have some of the most complex behavioral health conditions. And many of these are people who are experiencing chronic homelessness. So 30, I should say 30% of those funds are to be dedicated to housing resources coming from the recognition. And I think most clinicians will tell you that it's pretty hard to get stable without a roof over your head. And in fact, it's probably next to impossible. So investing in what we know helps both improve housing outcomes, but also behavioral outcomes by supporting and funding housing. So with those two new funding streams, the flex pool models we think will be very key in helping us rapidly secure units, even in really tight housing markets, which we've shown we can do. And we at through our folks, my dear colleagues at the Department of Healthcare Services have been doing a ton of TA and bringing out some of the total experts from across California who've done this in different parts of the state to help bring it statewide. And so we've got some useful toolkits and some great TA. So I couldn't help but share, and you'll get a link in the chat if you're interested in learning about how flexible housing subsidy pools could be either expanded or brought to your community. So thanks.
Fantastic. I'm seeing a few questions. We threw out terms like recuperative care and street medicine. I'm looking right at you, Michelle, so don't go on mute, because I'm going to ask you maybe to explain briefly what are street medicine? What does it mean to bring outreach medical care out to where people are? Both what is it and maybe briefly how it's paid for, and likewise with recuperative or respite care. What is it, and how do communities go about setting it up and funding those services?
Great. Can I just add one last comment to Corinne's wonderful
Absolutely.
explanation?
Yes.
Just about operationalizing some of the work that we're doing. So just want to be really crystal clear that in California right now, our managed care plans can pay for things like housing deposits, housing navigation, tenancy sustaining services, right? Recognizing that finding housing and keeping a person housed stabilizes them. The success, and we've seen this now across the state, requires real practical, explicit coordination between the continuums of care, managed care plans, county behavioral health departments, and housing developers and operators. And many COCs, especially those anchored at the county level, are really in a strong position to lead this alignment. We're actually seeing COC lead agencies and providers contracting directly with managed care plans, which is unheard of and amazing. So this really ensures that the experts already doing the work are the ones being reimbursed for it. So I just wanted to add that little piece to the last answer. So
time to make friends with your managed care plan. If you don't know who your managed care plan is, I ask you to please do that today. Thanks, Michelle.
I love talking about street medicine. So, as we've talked about, many unhoused individuals have really lost trust in the traditional medical system or just face insurmountable logistical barriers to getting to a brick and mortar clinic. So, street medicine can be both an appropriate fix to meet people where they are and or a bridge to more traditional care. A growing number of street medicine teams are developing the capacity to deliver high quality primary care to unsheltered individuals, sometimes with the aid of mobile health clinics. Other providers focus on urgent care and sort of use that responsive model to rebuild the trust that's necessary to eventually connect patients to a more traditional brick and mortar medical home. Um, as Robynne so eloquently said before, most of the teams are embedding people with lived experience as peers and community health workers to help with that trust building. And it's one of the reasons that street medicine teams are so well poised to work under CalAIM as what we call enhanced care managers for unhoused folks. So not only are they delivering healthcare directly to people, but they are providing care management, sometimes even housing navigation. And recent changes to Medi-Cal policy allow providers to bill for clinical and case management or health worker services delivered on the street. What we need to do is expand the number of contracts with managed care plans to really allow those street medicine teams to leverage this new guidance. I'm happy to speak about recuperative care as well. I could spend hours talking about these topics, and I'm also recognizing that we just have about 5 minutes left. But really quickly, recuperative care is it's care that can look like a spectrum of things, right? So it's really designed um, in part by the community in which it's launching, sort of leveraging the local assets and the people and organizations. But essentially, um, traditionally, it was care for people leaving the hospital. I think it's been adapted to be available to prevent hospitalization. So, one example is that street medicine teams are now referring people that they find on the street to recuperative care before they need an emergency room visit or hospitalization. They are not licensed, so there is a lot of flexibility in how care is delivered. Some are essentially leveraging spaces in shelters or interim housing units to provide mostly intensive care coordination, and some look like nursing homes for all intents and purposes. And then there's everything in between. The National Healthcare for the Homeless Council has an initiative called the NIMARC, the National Institute for Medical Respite Care. They have an incredible amount of resources about medical respite care, many of which are on our website, including like how to launch a medical respite program in your own community. So I encourage folks to check out those resources.
Fabulous. I'm going to do a round robin with our few minutes left, but before I do, Corinne, two quick questions for you. How long does California have the waiver? And if you are in another state, as many of our attendees are, and you're interested in getting, this kind of advocacy going in your state, what would be the recommendation?
So we are ending our one of our waivers, the CalAIM waivers, but we have a new one coming, and I will also share that we have had some amazing. So again, this is a CalAIM work, lots of work around housing. That's a part of one of these waivers. I'll share that we found that members who used at least one of our housing-related supports, we call them the housing trio, they had reduced inpatient visits by 24% and reduced emergency department visits by 13%. So what this suggests is that connecting members experiencing homelessness to housing services helps them better engage with the healthcare system and reduces the reliance on emergency care. So we all like saving money. Saving money is important. We are in a tough budget climate, but I think what really matters here is that we are seeing better health outcomes, and that's something we can be really proud of. So I think all that to say, we have a great case for continuing this really important work that we're doing. And then the other thing I'll say is that for our transitional rent, which is, as we've said, launching in January, big upcoming milestone for us, that is a part of a 5-year waiver that just started. So we're looking forward to a good runway to demonstrate how it too will both save funding, but also improve health outcomes for Californians.
Wonderful. We are really in our last minute here. So maybe in 3 to 5 words, what is the thing you would love to see with healthcare system and housing working together to improve the care of people experiencing homelessness? Anyone want to jump in quickly?
I'll just say very fast, support complex systems and how they get navigated. Just because it's hard doesn't mean we shouldn't do it.
Love it.
I'll jump in
Go ahead.
And bring up something that we haven't really talked about, but data is our most powerful tool for equity. We can't fix what we don't measure. Because deep racial disparities exist at the intersection of homelessness and health, we have to prioritize data that is disaggregated by race and ethnicity, and this clarity allows us to move beyond anecdotal evidence, hold systems accountable, and target resources where they're needed most.
Love it. Corinne.
I'll say this is a moment where I think we should keep our eye on the prize, the gold standard permanent supportive housing. This is an important moment for us to be really lifting up the value of permanent supportive housing to both improve health outcomes and end homelessness. Despite no changes, we know in California that this is what solves homelessness and this is what makes us a healthy state. So keeping our eye on the prize is my last word.
I love it. I'm going to turn it back to Robynne Craig and thank everyone for attending. And thank you to our absolutely incredible panelists for this really, really fantastic discussion.
Discussion. Thank you, everyone. That wraps up our program today. A video of the recording will be available on our website within the next 2 weeks. So keep an eye on our social media channels and your inbox for an announcement when that's available. And please fill out a survey to let us know how we did today. The survey will pop up once you hop off the Zoom call. Yeah, and thanks again to all of our panelists and all of you for joining us. Enjoy the rest of your day.